This is Nancy, one of the Care Queens, with the final video in this series on insomnia. We have come to prescribed medications by a medical practitioner and dispensed by a pharmacist. Every medical practitioner, whether a physician, nurse practitioner, or a PA, will have their own favorite medications to prescribe. So know that these suggestions may not be in the same order as your medical staff would recommend. When over-the-counter medications haven't worked, often the first medication that's suggested is trazodone. Trazodone is an antidepressant primarily used to treat major depressive disorder, but it's often prescribed off-label for insomnia due to its sedative effects. It belongs to the class of serotonin antagonists and reuptake inhibitors. The starting dose is usually 25 milligrams, but may be increased to 50. It can have the valuable effect of course, in treating the depression that many hospice patients also experience. So, did it work? If so, great, keep using it. If not, and the patient is having difficulty falling asleep, the next line might be a benzodiazepine or a benzo. They're a class of drugs that act as a central nervous system depressant and are primarily used for anxiety and insomnia. They also can allow muscle relaxation and seizure control. Generally, we are talking about lorazepam, known as Ativan, or alprazolam, known as Xanax. The dose of that bedtime lorazepam is usually a 0.5 milligram tab to start, but it can be increased up to 2 milligrams. It may be given PRN as needed, or a schedule if a pattern has been established. Alprazolam, another benzo, is prescribed at 0.25 to 1 milligram PRN or scheduled. I must say that at hospice, we often bypass the initial use of trazodone, and we go to a benzo such as lorazepam right away because it's included in so many of the comfort or rescue packs that are delivered to a patient when they're first admitted to hospice care. So it's right there and ready for a trial when needed. Remember, we're using this for the patient who can't get to sleep, although lorazepam can generally be prescribed PRN every 4 hours in case there needs to be repeated during the middle of the night. I might add a suggestion tip about how to manage the med, and that would be by putting one in a small cup next to the bedside. That way, if the patient finds they're having trouble getting to sleep or they wake up in the middle of the night and can't get back to sleep, the medication is right there and they can take it immediately. They don't have to get out of bed, find it, and then be fully awakened. And then a family member or the patient can check the cup the next day to see if it was used, document it so the hospice team knows what was being used and if it was regular and maybe needs to be scheduled. Let's go back to the trazodone. You tried the trazodone at the beginning dosage and it wasn't fully effective. The patient isn't having trouble falling asleep perhaps, but they wake up and can't get back to or stay asleep. Let's talk to that PCP and consider the increase of the dose at the bedtime dose from 50 to as high as 400 milligrams. However, another medication might be considered at that time, and it could be temazepam or Restoril. It's also a benzo, and it has a short to intermediate half-life, usually 8 to 20 hours. And so it's effective for both getting the patient to sleep and helping to carry them right through to the morning without extreme next-day drowsiness, although some grogginess might occur. With these medications discussed, some patients will still have difficulty with sleep. So, if the therapy is ineffective, please consider increasing the dosage of each medication to a maximum. And if it's still ineffective with one medication, well then switch to another one of the other ones we've talked about. If all of the therapy is ineffective, and of course you have been discussing each step and getting your orders from the medical provider, then it may be time for the team to consult with a hospice pharmacist. Nurses, you must document carefully all of the steps that have been attempted, which medication, the dosage, what were the changes and the efficacy of each change. Again, you're going to have to go back and interview the patient, the caregiver, the family to really find out how each change has affected the patient. Hopefully you can nip insomnia in the bud before you're having to go as far as a consultation with a hospice pharmacist. So in conclusion, let's get back to the basics of sleep hygiene first, and then follow the steps for medication use. Thanks for your attention, and good luck getting your patient and the care team and the families a good, restful night's sleep. Please visit our website, the Hospice Care Plan, pick up your copy of our booklet. Don't forget our blog. Please make comments and questions. Ask questions. That's how we know what more information and support you need in your path to death. Of course, subscribe to our YouTube channel, the Hospice Care Plan. And remember, Brenda and I are the Care Queens because our motto is care is treatment.